This is an interesting case of a complex embolization that we had done recently. This was the case of a 54-year-old male. He had undergone a right sided upper lobectomy, and post that, he developed septated pleural effusion, for which blind bedside ICD insertion was done. Now, post the ICD insertion, there was no column movement of air, and therefore the ICD was removed and a second ICD was inserted. Now, 12 hours after the second ICD insertion, the patient deteriorated clinically. There was some local site swelling and hemorrhagic output from the new ICD. The patient became hemodynamically unstable with hypotension and tachycardia, for which he was shifted to the ICU, and we advised for an urgent triple phase CT scan of the chest. The initial CT suggested a pseudoaneurysm, most likely arising from the right hepatic artery, and there was early venous opacification of the right hepatic vein as well. We suspected a right hepatic arteriovenous fistula secondary to the ICD insertion, and the patient was taken to the DSA for an urgent embolization. Now, we started the angio with a marker placed at the site of the initial ICD insertion, and we started with the celiac angiogram. The celiac angiogram was more or less normal. We could not demonstrate any active arterial bleeder. We could not detect the pseudoaneurysm which was seen on the CT from the right hepatic artery or its branches. Following this, based on the CT, we went ahead and did a selective angiogram from the right anterior hepatic artery. We were unable to demonstrate the aneurysm from this angiogram as well. These are the images from the selective angiogram done from the right posterior hepatic artery. We were unable to detect the aneurysm from this selective angiogram as well. Superselective angiograms from the segment 6 artery was also normal, and no active arterial extravasation of contrast was noted. So we started looking for other uncommon arteries which were a possible source of the bleed. So we went ahead and did a posterior intercostal arterial angiogram from the arterial level based on the marker placed. However, this was also normal. There was no blush seen. For the completion of the study, we also did the angiogram from the posterior intercostal artery at the level 1 above, as well as at the level 1 below the level of marker placement. However, it was unable to localize the artery, which was responsible for the bleed. Following this, we went ahead and did a right subclavian artery angiogram with a right internal mammary angiogram, with the suspicion that probably it was the anterior thoracic artery which was responsible for the bleed, since this was post an ICD insertion. However, this was normal as well. For the completion of the study, we went ahead and did an axillary artery angiogram, and finally, some blush was noted from one of the distal intramuscular branches of the axillary artery. So this is a spot image showing the marker as well as the blush, the contrast blotch seen as a pseudoaneurysm. This was possibly from the intramuscular branch of the lateral thoracic artery, which is a branch of the axillary artery. Now, again, looking at the location, there was a very difficult possibility of cannulating this artery superselectively. So superselective cannulation was not possible in this artery. So what we did was, based on the CT, we went ahead and did an ultrasound and a Doppler of this area based on the marker, and the Doppler clearly demonstrated the pseudoaneurysm, and it also showed the fistulous communication between the feeding artery as well as the draining right hepatic vein. Again, here's an image showing the feeding artery, which is probably the intramuscular branch of the lateral thoracic artery, the pseudoaneurysm or the blotching, as well as the draining hepatic vein, all seen on ultrasound and Doppler. So now, since endovascular superselective embolization was not possible, we had two options here. We obviously thought that yes, percutaneous embolization is a good option in this case, but we have two options here. Either we directly puncture the aneurysmal sac and place glue, or the other option was that since the feeding artery was seen, using a micropuncture set, we could probably get a percutaneous access of the feeding artery, and this would ensure a more complete embolization. So here's the image showing the feeding artery as seen in yellow. We placed a micropuncture needle from the micropuncture set, and we directly punctured this feeding artery just like how we take our radial punctures. We thought that this would ensure a more complete embolization rather than puncturing the aneurysmal sac or the fistulous communication directly. The image to the right shows the wire placed in the artery and the wire passage through the artery into the fistulous tract and into the aneurysm. Again, a representative image here showing the intramuscular branch of the lateral thoracic artery, the fistulous communication and the aneurysm and the hepatic vein, and the image to the right showing the wire and its passage from the lateral thoracic artery through the aneurysm and into the hepatic vein. Now, this was the angio taken through the dilator of the micropuncture sheath. So, across the wire, we placed the dilator and we took a run. This run clearly shows the aneurysm, the pseudoaneurysm, as well as the early venous opacification of the hepatic vein. So now at this point, we thought that yes, this is a good point for embolization. So we started with 50% glue, that is 1:1. And this is the image showing glue both in the hepatic vein as well as in the aneurysmal sac. So this is the last fluoros spot image showing the glue cast in the hepatic vein, in the aneurysm, as well as in the feeding artery, which is the intramuscular branch of the lateral thoracic artery. So in this case, what we did differently was that rather than directly puncturing the aneurysmal sac for a percutaneous glue embolization, which we routinely do when endovascular embolization is not possible, we took a percutaneous access of the feeding artery using the micropuncture set. And we thought that this would give a more complete embolization than the direct puncture of the aneurysm itself.